Hello and welcome to Conversations with Dr. Bachner. It is Howard Bachner, Editor-in-Chief of JAMA. And it's rare that I find myself proud of something that our journal is doing. You know, we have a responsibility each day to present good and high-quality research to the world, but this is a particularly unique day. Simultaneously, we are publishing 5 papers, and the WHO is releasing a document entitled Corticosteroids for COVID-19, a Living Guidance to September 2020. I'm joined today by a number of individuals who have been part of this remarkable effort. Jonathan Sterne, who is the lead author on a meta-analysis, which I'll explain in a bit. Jonathan is a professor of medical statistics and epidemiology at Bristol Medical School. Todd Rice, who along with Hallie Prescott has summarized the 3 randomized clinical trials and the meta-analysis that are all being published simultaneously in JAMA as we speak in an editorial. And Janet Diaz. Janet is the head of the clinical care group within the WHO Emergencies Program, and Janet and her group has been responsible for this document. But before we start, and I ask each of them to make some introductory comments, I wanted to inform our viewers and our listeners what we're actually publishing today. So there are 3 randomized clinical trials. There's a single meta-analysis, and then there is an editorial. So the first clinical trial, the effect of hydrocortisone on 21-day mortality or respiratory support among critically ill patients with COVID-19, a randomized clinical trial. First author is Pierre-François Dequin for the CAPE, COVID trial group, and the CRIX-TIGR-CEP group. This is a study that intended to enroll 290 patients, was stopped early after the announcement of recovery, ultimately enrolling about 150 patients. This study was done in France. The second study, Bruno Tomazini and Luciana Azevedo are the first and senior authors. This is from Brazil. The effect of dexamethasone on days alive and ventilator-free in patients with moderate or severe acute respiratory distress syndrome and COVID-19, the CoDEX randomized clinical trial. This study included 299 patients. And the third clinical trial, the effect of hydrocortisone on mortality and organ support in patients with severe COVID-19, the REMAP-CAP COVID-19 corticosteroid domain randomized clinical trial. The writing group, the REMAP-CAP writing committee, corresponding author is Derek Angus. This study ultimately enrolled 384 patients, conducted in 121 sites in 8 countries. And the meta-analysis, Jonathan led the effort, the writing group, the WHO Rapid Evidence Appraisal for COVID-19 Therapies, REACT Working Group. The title of the meta-analysis, Association between Administration of Systemic Corticosteroids and Mortality Among Critically Ill Patients with COVID-19, a meta-analysis. I must thank the peer reviewers. Each peer reviewer saw all 4 papers. They conducted peer review in 2 days or 3 days. These manuscripts were processed at JAMA because the authors, our senior editors, our editorial group, and the authors worked daily each day over 3 weeks to make sure that we could publish all 5 articles simultaneously. Jonathan, what do the results say?
Thanks, Howard, and thanks very much for the introduction. And I should probably mention, and in addition to the groups that you've mentioned, the work here was led by Srin Murthy and John Marshall, who've been part of the WHO Clinical Characterizations Group with Janet, and who started convening the trial investigators way back in April. And perhaps mention the investigators of 3 trials who you haven't mentioned so far. Bindu, steroid SARI trial in China, Jesus Villar, and Anders Perner, who also led trials and also contributed to the effort. Everybody watching will know that the only drug demonstrated to reduce mortality in COVID-19 is dexamethasone, and that we learned that on the 16th of June when the recovery trial, very large UK-based trial, released its results. At that time, the investigators of nearly all the world's trials of corticosteroids in critically ill, the sickest patients with COVID-19, were already talking about a collaboration where they would pool and rapidly disseminate their results. And once the recovery trial had published, it was agreed that that was what would be done. We agreed that the last date for recruitment would be the 9th of June, so that patients' care couldn't have been affected by the release of recovery results. And that meant that the last day for follow-up for 28-day mortality was the 6th of July. And as you know, because you've been part of this process, Howard, subsequent to that, the trials rapidly combined their data. And we should perhaps mention that it's really unprecedented. The trial authors are taking a big risk when they share their data in advance of publication, because the concern that any trial team will have is that if their data are published by someone else, their own paper will become less interesting. So in a spirit of trust, and because of the urgency of these results for the care of patients worldwide, the trial investigators shared their data. We put those together in a meta-analysis. Everybody wrote their papers at the same time, and we were able to submit the paper within 2 weeks to JAMA, and it's been a real pleasure working with you and your colleagues to get into finished and to get us publication to. In terms of the show, the bottom line is that these are the sickest patients who are being treated with corticosteroids in these trials. And mortality is very high. It's about 40% in the absence of treatment with corticosteroids. Treatment with corticosteroids reduces a mortality of 40% to 32%. That's a 20% relative reduction, or if you like, a better way to think about it, an easy way to think about it, is that out of every 100 patients treated with corticosteroids, 8 additional patients do not die. And a final way to think about it is that approximately for every 12 patients that you treat, you save 1 life. And that's really the bottom line from these results.
Janet, 2 questions for you, and then I'll go to Todd. The first is, how did you pull it off? And then what does the new WHO guidelines recommend? So the first is, how did you get everyone to cooperate? It's not something that we often do. We're in the middle of a pandemic, and I really have to thank all of the investigators. And I want to echo something that Jonathan said. There's more than these 3 clinical trials in the meta-analysis, but you have to read the paper to see what's in it. But Janet, how did WHO pull it off, and what do the new guidelines say?
Well, thank you so much, Howard. It's actually a privilege and a pleasure to be here, and it's kind of it's unbelievable almost that we actually made it to the end. And so I think to start with, we do want to say thank you to all the collaborators here internally to WHO, with my good colleague John Grove, who leads the quality assurance norms and standards, really a key member of our group here, to the methods support team that worked with us, the external methods support team, and that's the Magic Ecosystem Foundation. So both Francois Lamontagne, who is our methods chair, and Per Olav Vanvik, also from Magic. And then, of course, to all the trialists, as you already described and what Jonathan added on. Really, for me, it was something that we knew we wanted to bring evidence, science to the bedside. So how quickly can we bring good science to inform patient care? As WHO, we want to write, evidence-based guidelines. We want to bring the best practices to the field, especially to member state, to all our member states, and especially to countries that really rely on our guidance, that don't produce their own national guidance, that don't have their own, processes or national societies that will make trustworthy and transparent guidances, as well as the policymakers who are looking to support countries and procurement and distribution of life-saving medicines. So that was the impetus, and we knew from the beginning, even from February, that we wanted to prioritize corticosteroids, because we knew people were going to start using corticosteroids, because it was around, and we like to do that in intensive care. Some people like to do that in intensive care, and that we should just take this opportunity to study it. And so, luckily, many investigators started to study it, and we saw this fantastic opportunity. Then, can we bring the investigators together and try to make pool analysis, the idea of the prospective meta-analysis, and is this possible? So we ventured on this experiment, and of course I want to acknowledge Sterne Murthy and John Marshall, our good colleagues who chair the WHO clinical research working group where a focus was on clinical characterization research and clinical management research. And we together, reached out to the investigators and started to convene on a weekly basis the development of this protocol. And then Jonathan, joined our team. And I think it was just really with the good nature of everyone, with the transparency, with the trust that we had in each other. And in the process, and I think thinking of the patient at the bedside, I think we were, all the PIs most of them are intensivists, working in busy ICUs, understanding, that we need to bring good evidence to inform guidance. And I think just we're superb in the collaboration effort to help WHO, to work with WHO. And there was quite a bonding experience in the process that we went through. And then, I think from the getting the evidence, pulling it together, from the technical side, then rapidly trying to package, convene the GDG, which of course I wanted to acknowledge there's 23 of them and they're all in the guideline, that you can see who they were, but really them being, able to see data, give us good feedback, see more data, even though it was, unpublished data, we were seeing data early. And I think that was also a new, an innovative, an important process. So the manuscripts were not published when we saw them. So we saw the data early. That allowed us to start the process, wait till the manuscripts were peer reviewed, submitted, and refine our guidance. But at least we were able to start early. So by the time all these studies were going to become public, we were able to actually then also produce our guidance. And then I have to thank you at JAMA for the collaborative, for the collaboration as well, understanding, the need for doing good reviews, but doing them quickly, and really just a collaborative effort on everyone, that everyone took part, in their part of this puzzle, as we were trying to put the puzzle together. So in regards to what does the guidance say? So there are two recommendations in the guidance, but it is, it's about 18 pages long, I think, with a graded evidence, with a summary of findings tables, and all the description of the trials. But the evidence says the recommendations are for one, a strong recommendation for the use of corticosteroids in patients with severe or critical COVID-19. And that evidence, and that is a strong recommendation. It is based on a moderate certainty for the reasons of the absolute risk reductions that Jonathan already explained. The second recommendation is for a recommendation against the use of corticosteroids in mild COVID-19. And that recommendation was based on low certainty of evidence, but with a concern that could be increased deaths with the use of corticosteroids in patients with mild COVID-19. So the guidance itself, those are the highlights. The guidance itself goes through the entire process of how we convene the meetings, the discussions around things, and a lot of things about practicalities around implementation, and also limitations and things that need to be addressed for the future. So thank you.
Thanks, Janet. So Todd, you with Hallie Prescott have written the editorial that summarizes the three clinical trials, the meta-analysis. The title of the editorial is Corticosteroids and COVID-19 ARDS, Evidence and Hope During the Pandemic. So as Jonathan said, 8 per 100 treated, lives saved, about a number needed to treat 1 in 12. So why did it work, Todd? Why, after 20 years of research of steroids and sepsis, steroids and ARDS, why do you think it's worked?
Yeah, well, I got the hard question, huh, Howard? No, I'm kidding. I think that this is a disease that has phases, and the initial phase is damage done by the virus. And then I think it's becoming more and more clear that a later phase of this disease is dominated by an inflammatory component and hyperinflammation. And I think steroids are very good at decreasing that inflammatory component and reducing the damage and the effects of hyperinflammation in the body. And I think that's probably the mechanism, although we don't know for sure, that's probably the mechanism as to how the steroids are working in this situation.
Now, one of the questions that's already come in, it's addressed in the meta-analysis and in your editorial, is hydrocortisone or dexamethasone. And Jonathan, I'll return to you because this is going to be a big issue around the world because every country doesn't have both. Both the WHO recommendation as well as the meta-analysis goes into dose. I think that's a little less critical than actually hydrocortisone or dexamethasone. But Todd, could you comment about whether or not do you have a sense if there's a preference for one over the other?
Yeah, my take on these data are that it appears to be a class effect, and that it's from the steroids and not from a specific steroid, dexamethasone or hydrocortisone. And I think it opens up to what's the steroid that you have that you can easily get, and that's what you should use. The effect sizes appear to be very similar between dexamethasone and hydrocortisone, and I don't think, based off of these data, that you could say there's a preference for one over the other.
Jonathan and Janet. Jonathan, is that your reading of the data? And Janet, was that the conclusion of the guideline work group for WHO? So Jonathan, you first.
Yes, absolutely. So the estimated effect of hydrocortisone, as Todd said, was very similar and consistent with the estimated effect of dexamethasone. Although, because fewer patients had been randomized in trials of hydrocortisone, the confidence interval was wider, but the effects look very consistent. One trial and then one additional trial that we located late had randomized patients to a third steroid, methylprednisolone, and there are sufficiently few patients randomized that the effect is imprecisely estimated, and the truth is we just don't know. But I think one of the reasons that these results are very good news worldwide is that it really says that there are two options. As Todd says, it's hard to choose between dexamethasone and hydrocortisone. They're both routinely used in critical care, and therefore, if one isn't available, the other one should be used.
Janet, the WHO guidelines, do they generally agree? Either it's a class effect and either of the two drugs that we've been talking about are options?
Yeah, so when we presented the data to the guideline development panel, yes, they agreed that either dexamethasone or hydrocortisone, as well, giving the options if those aren't available, then using an equivalent dose of prednisone or methylprednisolone. So a class effect.
Now let's move to two really difficult and complicated questions. Todd, I'll start with you. And Janet mentioned it. They're recommending against the use of corticosteroids in mild illness. But if you have a 70-year-old who's breathing at 50, may not have met the criteria that would have gotten him or her into any of these studies, but you think is going to deteriorate in the next 3 or 4 days. And this actually may be the majority of patients who end up in the hospital. What do you do?
Yeah, I think this is hard to clinically implement these data and understand. I think there's the signal from the recovery group that maybe dexamethasone isn't that helpful in those patients, which doesn't bother me that much. What bothers me more is this potential signal that maybe it's even
right
in those patients. And then I'm left with the question of in the recovery trial that was based off of whether or not you were on oxygen, which at least in the United States is not a very clear line as to how people get put on oxygen. And so it leads me to the question of there probably is a group that these may not be the best treatment for, and how do we identify that group, and how do we avoid giving them to patients that potentially could be harmed by them? And what you've proposed, Howard, which I love the idea of predictive modeling of who's going to get worse, who's at risk for becoming critically ill, where we know that they work. And I think there's some work to do to truly understand where that dividing line is, and who the population that, it's pretty clear we absolutely should give it, and who the population is that it's clear that we absolutely should not give it.
Janet, did the WHO Guideline Committee wrestle with this? Because, as I said, this is one of the great clinical questions. It's easier if you know the person is, as I said, breathing at 70, has huge O2 demands and is about to be intubated. They get steroids, but it's this group on the way to that presentation. And as critical care places, hospitals around the country are less busy, they may be able to pay more attention to these patients who are getting worse. Did the Guideline Committee wrestle with this group?
We did, and actually, if you read the guideline in Table 1, there's a little nuanced statement about that it can't be so black and white, right? It could be that someone has a saturation of 93% or
Right.
4%, but clinically they look like they're on a downward scale. Then the clinical judgment should also be used to consider it. And I think where we struggled at the beginning, because at the beginning we only had the recovery data, and they did the two subgroups, with oxygen or no oxygen and ventilation. And so when we wrote our guidance, there was a discussion as, do we use the same things? We recommended it in patients on oxygen. We recommended in patients on ventilation. And that seemed difficult for us to do, because we didn't want to make it based on the intervention that the patients were receiving already, because that can be varied depending on the resources you have. So we chose then to say, we made the assumption that most patients that would be put on oxygen is because they have certain indications for oxygen. And in our previous WHO classification system, we have a severe classification, which is people who usually are on oxygen or have some signs of respiratory distress, and we have a critical classification. So we chose to use those classifications, but then with a little bit of a nuanced statement saying that it's not so black and white because we don't know. So clinical judgment in that gray period, in that gray zone where you think someone is on the way crashing, but not yet there. So.
Jonathan, I mean, you've lived with this literally lived with this data since we've had a lot of emails back and forth, including your quasi vacation. You've lived with this data for almost 3 months. Having looked at the 7 or 8 clinical trials, do you have a sense of how to differentiate patients?
So, one of the area we're talking about has indeed been the hardest bits of text to write, and the bit where the authors have argued most about the presentation of the results. And for people who are interested, I would encourage people to look at the supplementary material, right, where we have additional plots that might help. So we do not have definitive results here, but we have a couple of hints. And the first is that the trials recruited critically ill patients, but the definition of critically ill varied between the trials. Okay. In 3 of the trials, we really only included patients who were invasively mechanically ventilated. They had a tube down their throat to help them breathe. But in the 3 of the trials, there were a few patients who were not invasively mechanically ventilated. Sorry, in 4 of the trials, there were a small group of patients who were not invasively mechanically ventilated when they were recruited to the trial. And the signal, it's only a signal, was that the benefit was, if anything, greater in the patients who were not invasively mechanically ventilated at randomization. And that tends us in the direction that both Todd and Janet have mentioned, that it's not that you need the intervention of a tube down your throat to get benefit. It's that the benefit is in the sickest patients, but not necessarily waiting until there's a tube in the throat. And the second piece of evidence that points in the same direction is that the benefit of corticosteroids appeared greater in patients who didn't receive medicine to support their blood pressure, the sickest patients. So it appeared greater in the patients who were not so sick that they needed those additional medications. So Todd may want to comment further, but those were 2 pieces of evidence that really this is about being sufficiently sick, that you're getting the problems resulting from the very active immune system, rather than waiting until there is a particular intervention given.
Todd, can you comment on Jonathan's identification of the clinical information within the trials? Because I do think we're talking about what is likely the majority of patients that come into the hospital and potentially are in a critical care unit.
Yeah, I think he explained it pretty well. I think that, we talk about should we give this when the patient's on the ventilator? Should we not give it when the patient's not on the ventilator? And I think the data are pretty suggestive that the ventilator is not necessarily the trigger for when these should be started, and that giving them to patients that are pre-ventilator before they go on is also beneficial. And we can argue about, is it more beneficial, is it less beneficial? I'm not sure that the data are that definitive as to more or less, but I think they're pretty definitive that they're still beneficial.
Go ahead, Jonathan.
I'll tell you really quick.
Go ahead.
Really quick, let me say this, then you can comment. One of the things that Holly and I struggled with a lot was what to say about the shock group.
Could you explain the shock group? People may not know what you mean by the shock group.
Yeah, the group that had low blood pressure were critically ill with COVID, but also had low blood pressure and or needed medicines to raise their blood pressure to keep it in the normal range. And we struggled with it because there, as I think you all know, there are data for patients that have shock from an infection, septic shock, that steroids may help that group. Forget COVID. Steroids may help that group. And so when the signal looked like it was less and maybe not even present in those patients, we looked at that pretty hard and talked about it actually a lot among her and I. And I think it's a hard signal to understand because in many environments, patients that were already in shock, had low blood pressure, may not be eligible for randomization because their doctor already thinks I'm giving this patient steroids because I'm confident that it helps these patients. And then in addition, the REMAP paper has a shock arm, but less than half the patients in that arm actually have shock and get the shock treatment. And so, I think that makes it hard to interpret those data too. Clinically, I'll tell you, I'm not withholding the steroids in patients that I have with COVID that are critically ill that have low blood pressure. I'm giving it to those patients also.
Janet, do you want to comment? No, and I just want to point out to the people who are watching or who will eventually listen, Janet is a critical care physician who trained in San Francisco. And Janet, you can depart from whatever the WHO guidelines are and say what you would do, but I know you have to probably be pretty careful about that. But can you just follow up on what Todd just said, because I know it's a complicated issue. Besides, who should get it? This kind of the patients with shock or shock-like syndrome.
Well, yeah, I agree with Todd, actually. I would give them the corticosteroid. I think for, based on the guidelines, it's also, we would give based on the WHO would recommend for patients with severe or critical COVID-19 to use corticosteroids. And that's the recommendation. And that would include someone with shock or without shock. So there's no distinction being made at all in the guidance. And it wasn't really a topic of conversation. And I do think, from the literature, from the non-COVID septic shock literature, from the meta-analysis that were done and that, have been done for corticosteroids, that there is, reasons to believe that it is beneficial and, suggestive of benefit in septic shock as well as in potentially sepsis. So,
Jonathan, there's another important piece of evidence that I should quickly mention, which is that the recovery trial randomized around 4,000 patients, a really, really large number, who were receiving oxygen in a variety of ways, but were not so sick that they were invasively mechanically ventilated. And mortality was reduced in those patients. And we included those data, although they're not part of the main prospective meta-analysis. We've included that data in figure 3 in our paper. So I think it's really important to bear in mind that a much wider range of patients in recovery and a very large number of patients also provide evidence that for patients who needed oxygen, in the context of UK healthcare, mortality was reduced by corticosteroids.
Rob Golub, who's Director of Scientific Review at JAMA, along with Chris Muse. Rob always says, people need to understand the abstract is just a skeleton of the paper, and the paper just only is a small part of the entire study. So I really, oftentimes when people talk to me about clinical trials, I often say, you actually have to read the entire paper sometimes. And in this case, I think it really is worth reading all of the meta-analysis, all of the trials, and particularly look at the supplement. And then I want to go to one additional question. Derek Angus and others have written in JAMA and other journals. We've learned quite a bit, but now more complicated questions have come up. The timing of drugs, combination drugs. So now, there's a literature around Remdesivir. I think it's mixed about its benefit. No definitive data yet about convalescent plasma. But Todd, how do you see the combination of drugs working now? With steroids is clearly the highest quality evidence with the greatest gain. Remdesivir, some gain. Plasma in the hearts of people, a lot of gain, not a lot of high quality data yet. So Todd, how do you see the combination of drugs working out?
Yeah, I think you summarized sort of the evidence level really well. I don't think we know, because I don't think we have good data of these being used together. Most of these patients in these steroid trials were pre-remdesivir, and they didn't get remdesivir. So understanding the combination of the two, I think, is a little bit of a data-free zone. But as I started at the beginning, telling you at least what I think is the mechanisms, I think the mechanisms that these treatments would work through are different. So remdesivir is an antiviral. Steroids, I think, decrease the inflammatory reaction. And to me, it makes perfect sense that they should be synergistic and work together. And I think that, in my practice, I would use them together, and I do use them together. I think convalescent plasma is a little bit of a fly in the ointment, in the fact that its mechanism of action is also antiviral, and so it and remdesivir may not necessarily have combined effect when they're used together, and they may have similar mechanisms and similar benefit if convalescent plasma is shown beneficial. But I think both of those are distinct from steroids. And I think if you're using convalescent plasma, steroids are likely to add benefit to that. And if you're using remdesivir, steroids are likely to add benefit to that also.
Janet, before I go to you to comment, one of the things that comes up in the Q&A all the time when this question comes up, Todd, is there any reason to think that steroids would adversely affect the action of remdesivir or vice versa?
Yeah, I think, like I said, there's not a ton of data, but from what I know and from what I think we know from the data, I don't have any reason to believe that the two should have an antagonistic effect and that they couldn't be used together.
Janet, does the guideline make any comment about combination therapy?
No, we do not make any comment about combination therapy. In the ongoing uncertainties part of the guideline, we do discuss this in the sense of, with a strong recommendation for the use of corticosteroids in severe and critical disease, now that, let's say you're going to test immunomodulators, right? So in some ways, should they now be tested against corticosteroids, right? And so maybe the design of trials may need to be adjusted after this. And then in regards to other antivirals, direct antivirals, again, I agree with Todd. I don't think there would be any reason to think that they would not be synergistic, since they're working, or, not be, what am I trying to say? Not be, synergistic, I guess, in treating COVID. I think the timing of antivirals is the question as well. With those antivirals being perhaps earlier initiation when the viral loads are very high to get the best impact versus corticosteroids. What we're seeing now with corticosteroids is not necessarily the timing, but actually the point in the disease where you're having signs of the inflammatory response or severity signs.
Jonathan, I know you've really focused on steroids, but you've seen the data from all of the trials. Do you have a sense if there's an answer out there, or we need more information yet to begin to answer this question?
So I think the trials from now on, broadly speaking, are going to be assessing new therapy with corticosteroid compared with the absence of that new therapies, but corticosteroids. So what we're really going to learn about from here on in, at least in the critically ill patients, is about whether adding something else to corticosteroid therapy reduces mortality further than the corticosteroids have already reduced it. I think probably any of the four of us, and indeed any of the clinical research community out there would at this point say the same thing. I mean, I'm not sure what the total number of patients with COVID-19 to date is worldwide. It might be 25 million. We've seen that we can get definitive results from randomized trials involving a few thousand patients And for most of us involved in research, whether treatment or another treatment works is not a matter of opinion. It's just a matter of doing a randomized trial with sufficiently many patients, finding the answer, and then acting on the answer. It's not a political issue whether drug A works or doesn't work. It's just a matter of doing a randomized trials, finding out, and acting on the result. So we simply need to randomize patients to trials of, and this is of course being done, to trials of remdesivir, to trials of convalescent plasma, to trials of the new immune therapies that are coming on, to therapies. I mean, a really important area is whether we can find therapies that prevent progression to severe illness. And we're going to need large numbers of patients randomized in trials to do that. And then, I don't have a prior opinion. The investigators of the recovery trial, the senior investigators, told me that before they released their results, they had 10,000 tweets telling them that they were evil people for risking corticosteroids in these sick patients because they were going to kill them. And then after the results were released, they had 10,000 tweets, people who said they knew all along that corticosteroids were going to work. Truth is, if you don't know, do a randomized trial and find out, and please find out quickly because millions of patients need the answers.
I'd like to end there because I think it's a call to the scientific community and the clinical community, and there is always tension when you're taking care of patients who are doing poorly about how you can think about trying to put patients into a clinical trial. I think clearly steroids are now standard of care, so everything must be compared to steroids, but I think real progress will be made by conducting clinical trials and by the clinical trial community cooperating like they've done in this case. It's an extraordinary accomplishment and achievement. So this is Howard Bachner, Editor-in-Chief of JAMA. This has been Conversations with Dr. Bachner. Once again, I want to highlight the WHO guideline, living guidance, they call it, to September 2020, corticosteroids for COVID-19. It's being released simultaneously with our publications. The editorial is by Hallie Prescott and Todd Rice, who's joined me today, Corticosteroids and COVID-19 ARDS, Evidence and Hope During the Pandemic. Then a summary of the 3 trials. The effort was led by Jonathan Sterne from the University of Bristol, the WHO Rapid Evidence Appraisal for COVID-19 Therapies, Association between Administration of Systemic Corticosteroids and Mortality Among Critically Ill Patients with COVID-19, a meta-analysis. And then, of course, my ultimate thanks to Janet Diaz, who's the head of the clinical care within the WHO Emergencies Program, who has worked tirelessly with many other people, both at WHO and around the world, to get people to cooperate, assimilate data, and be able to really create a database that allows patients to get better. I can't thank the 3 of you enough, your co-investigators, and the efforts, and thank you for bringing the papers to JAMA. Take care.
Bye, everybody.
Bye-bye, everybody. Please stay healthy.
Bye. Thanks so much. See you.
Thank you.
Okay.
Bye-bye. Thank you.